Appropriations. Before we begin, I do want to walk through the COVID-19 safety protocols that are in place today. And again, I really want to thank all of our clerks and everyone who's really worked hard to get this set up and help us all stay safe and healthy. So thank you to them. But for today, we're going to be conducting this hearing following similar COVID protocols to what we have used in the past. Committee members are seated at least 6 feet apart. Some senators are participating by video conference. However, I do expect that this will be our final hybrid hearing, and we will be able to return to regular in-person hearings at our next hearing. Consistent with CDC guidance, those who are fully vaccinated do not need to wear a mask, though they may still choose to do so. And while we are unable to have the hearing fully open to the public or media for in-person attendance, live video is available on our committee website. And if you are in need of accommodations, including closed captioning, you can reach out to the committee or the Office of Congressional Accessibility Services. As of today, almost half of U.S. adults are fully vaccinated. And while we have a lot of work left yet to do to reach communities who still can't get vaccines and reassure people who still have many questions about them, we can see the light at the end of the tunnel. And I really want to thank all of our witnesses, especially Dr. Collins and Dr. Fauci, for putting in long hours and putting science first. Where we are at today is a testament to the tireless work scientists at NIH have been doing to study this disease and how we can best fight it, and to oversee clinical trials for vaccines and therapeutics and more to ensure they are safe and effective. And of course, as our witnesses know, our historically fast progress in fighting COVID-19 and developing safe and effective vaccines was actually years in the making. The pace of discovery we've seen this past year was made possible by research into mRNA vaccines we funded in response to Ebola and other viruses, and by a biomedical research enterprise that has been built over decades to become one of the most cutting edge in the world. This should be an important reminder when it comes to biomedical research. You can never fully predict how the discoveries of today will prepare you for the challenges of tomorrow. That's why you have to build a robust research enterprise and recruit diverse world-class talent and make sure scientists can do their work free from political interference. And President Biden's budget, which proposes over $40 billion for NIH and the largest increase in the agency's history, will go a long ways towards making sure we can continue to prioritize this. This budget will reinforce our work to fight COVID-19, along with many other diseases and disorders that threaten families in my home state of Washington or Missouri or across the country. It includes funding to improve treatments for addiction and substance use disorders, and funding to aid the fight against cancer, Alzheimer's disease, and rare diseases families across the country are grappling with. President Biden's budget request will also fund research to help us study the health effects of climate change, which may be increasing the number of infectious disease outbreaks, identify solutions to gun violence, which continues to claim tens of thousands of lives each year in this country, and root out the health inequities in our country, which are undermining the health of people of color, people with disabilities, rural communities, those paid low incomes, and more. The President has also proposed $6.5 billion for a new initiative, the Advanced Research Projects Agency for Health. Like the Defense Initiative, it is inspired by ARPA-H. ARPA-H is envisioned as breaking the mold for how cutting-edge research is conducted, speeding up the development of medical treatments by funding innovative projects. I'm interested to hear more about how it can add to NIH's work and operate as something truly distinct from its other traditional biomedical research programs. Of course, at the end of the day, innovation isn't just driven by new programs and new investments. It is driven by people, which is why with as much as we invest in NIH each year and as important as its work to its families, our families, we cannot afford to have this agency's potential limited or its success threatened by bias, discrimination, harassment, or assault in the workplace. Unfortunately, we know that in the biomedical research community, the prevalence of researchers of color is too low, and the prevalence of sexual harassment is too high. These are real problems with real consequences for biomedical research and the people who do the life-saving work we're all benefiting from today. I commend NIH for the efforts it has taken on both of these fronts so far. NIH has done work to examine barriers to diversity among its researcher ranks and how its own practices have reinforced structural biases that allow discrimination to persist. But more work remains to tear down barriers and create lasting change. And when it comes to sexual assault, Director Collins, I'm glad you've taken some forceful action to address the problem among the NIH workforce, but NIH must do more to use its enormous influence with the research community to enforce change in the nation's universities and research institutions. I expect NIH to continue building on its efforts so far to remove racism, discrimination, and harassment from research, and I will continue to follow up on that progress. Finally, as proud as we all are of our nation's biomedical research institutions, we don't invest billions of dollars in biomedical research out of pride, nor do we invest in them to help pharmaceutical companies make astronomical profits. We do it to bring new treatments, cures, and hope to people across the country and across the world. It is important that we never lose sight of this, because even the most brilliant miracle cure can only save people if they can actually get it. Just as I hope to work with my colleagues on both sides of the aisle to make life-saving investments in biomedical research like those proposed in the President's budget, I also hope we can work together to bring down the cost of health care, especially for prescription drugs, keep working towards universal health coverage, and bring the cures we are investing in to the families who need them. With that, I will turn it over to Senator Blunt for his remarks.
Well, thank you, Chair Murray. I appreciate having this hearing today and appreciate being able again to start this process with you as we did last week on our first hearing last week. I'm certainly glad that Dr. Collins and the Institute directors are here with us today. I think two of the directors are testifying before the committee the first time, and so welcome to the two of you. And this is a helpful relationship for us and hopefully for you. Certainly the challenges we've faced over the past year have been unanticipated and significant. I think the global pandemic reinforced the importance of the National Institutes of Health. In less than a year, NIH was able to take this novel coronavirus and help develop 2 FDA-authorized vaccines, 2 FDA-authorized therapeutics, and 16 rapid diagnostic tests, including the first FDA-authorized point-of-care diagnostic test for COVID-19 to combat its spread and its effects. A year ago, when we would have had a similar discussion, one of the big topics would be, why can't we get enough tests? NIH stepped up and really played a big role in seeing that we had enough tests. We haven't heard that discussion for a long time, and that doesn't mean that millions of tests aren't being taken every day. It just means we figured out at this committee and NIH to be part of meeting that need. It was revolutionary to watch NIH work, but it didn't just happen. In a time of crisis, during shutdowns, during social distancing, dealing with the disease that had never been seen before, the system and its nationwide grantees were able to use their expertise and infrastructure to, again, develop tests, treatments, and vaccines. Our research infrastructure was tested like never before, and, in my opinion, it succeeded in remarkable ways. I believe there are really 3 reasons for that. First, in the past 6 years, this committee and the Congress, in a bicameral, bipartisan way, have prioritized and invested in NIH. Within that 6-year time frame, funding for medical research increased by almost $13 billion, or nearly 34% over that 6 years after a decade at virtual level funding. This investment encouraged young scientists, young researchers, and mid-career researchers that were leaving the field before that to stay in the field. And with your insistence, Dr. Collins, some of that money every time was set aside to be sure that it was going to first-time grantees. We were able to shore up the research infrastructure across the country and provide research into mNRA, an idea that had never produced a vaccine before, and of course became the foundation for the two principal vaccines that were developed very much with the involvement of NIH. Our ability to pivot so quickly and so successfully to fighting COVID-19 could not have been accomplished had we stayed at the funding levels we were at 7 years ago. The buying power was not where it needed to be. Young researchers were leaving the field. Tough budgetary decisions meant that people were not only getting their applications rejected at significant levels, they just frankly stopped making a lot of applications. That's not your problem, by the way, today. Second, at the height of the pandemic, Congress gave the Department of Health and Human Services significant funding and flexibility to create Operation Warp Speed. It was successful in developing two FDA-authorized COVID-19 vaccines and commercializing another with the help of NIH because we united in our effort to make that happen. One of the things we did was to really invest in vaccines that we didn't think were certain to work but thought were likely to work. And that meant that vaccines were available when they got FDA approval rather than months after they got FDA approval. Because of that, fully half of all adults have been vaccinated now in the United States as we work toward a bigger number than that. We pushed private industry and worked with private industry in ways we had not before. I've said at the time, one way to win the horse race is to bet on all the horses. And I think to a great extent we did in the vaccine effort, bet on all the horses we thought had a chance to finish the race, and it made a difference. Finally, one of the most important lessons learned from the pandemic is the value of having the federal government on occasion as a more active partner in research and development instead of just a sponsor. The ambitious speed and goals that push private companies to research, develop, and manufacture a COVID-19 vaccine, along with what we did in testing, really created the kind of breakthroughs we needed. RADx, Warp Speed, I think put us in a different place than we would have been 2 years ago in thinking about how we can look at some of our research efforts in another way. That's why I want to work with the administration to support the ARPA-H initiative. This will be a new institute, or is proposed to be a new institute, and I think that's what should be the case. They'll have the flexibility and tools necessary to both nimbly and innovatively respond to both the next pandemic and also some of the big health issues we face today. This is a critical moment in a rapidly changing healthcare world. Finding those things that the kind of Warp Speed, Shark Tank, RADx relationship could enhance in cancer, in Alzheimer's, in every disease where there's an opportunity, where we see that moment and know that this is something that doesn't necessarily call for a 5-year research grant, but some sort of partnership different than that that moves toward a real conclusion sooner than we might otherwise be able to do that. ARPA-H should not do what the other institutes do, but it should do what the other institutes can't do in a cross-cutting way that goes throughout the institutes, looking for opportunities, frankly, in the other institutes where there's a breakthrough moment that we could look at differently. I think we can help fill gaps here that otherwise would not be filled, and look forward to that discussion. Now, also as someone working with Senator Murray for the last 8 years to increase the funding and the focus in what NIH has been doing, we clearly want to be sure that this somehow doesn't take away from the solid research that proved so effective in getting us ready for what we just saw. Dr. Collins, I look forward to working with you and Chair Murray and the administration in making ARPA-H a reality. I think there's a moment is ready for that. I think because of what's happened in the last 2 years, NIH is ready for that, and look forward to the discussion today.
Thank you very much, Senator Blunt. I will now introduce our witnesses. Dr. Francis Collins is the Director for the National Institutes of Health. Dr. Diana Bianchi is the Director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development. Dr. Anthony Fauci is the Director of the National Institute of Allergy and Infectious Diseases. Joining us virtually is Dr. Gary Gibbons. He's the Director of the National Heart, Lung, and Blood Institute. Dr. Eliseo Perez Estable is the Director of the National Institute on Minority Health and Health Disparities. Dr. Ned Sharpless is the Director of the National Cancer Institute. And finally, Dr. Bruce Tromberg is the Director of the National Institute of Biomedical Imaging and Bioengineering. So, Dr. Collins, we will turn to you for your opening remarks.
Thank you, Chair Murray and Ranking Member Blunt and distinguished members of the subcommittee. I am honored to be here today with my colleagues representing the National Institutes of Health, the NIH. I could spend hours describing the exciting work the President's budget is proposing for NIH, including major investments to address impacts of the COVID-19 pandemic, reduce health disparities and maternal mortality, improve mental health, broaden approaches to pain and opioid addiction, and establish a bold new agency within NIH called ARPA-H. But in our brief time together, it's also important to emphasize how steady funding increases that you have provided to NIH, starting well before the pandemic, made it possible for NIH to meet the challenges of the pandemic and to prepare for what comes next. Often at these hearings, I share a story of a patient whose life has been saved by NIH research. But in this uniquely challenging year, it's hard to single out any one person. In fact, all of the more than 160 million Americans who have received COVID-19 vaccines as of today are success stories made possible by the sustained investment that this committee made years ago to basic biomedical research. The road to these mRNA vaccines actually started back in the 1960s when the function of messenger RNA was first understood. These messengers carry instructions from the cell's DNA manual to produce the proteins that do the work. Now, for vaccines, we knew that certain proteins, like the spike proteins on the coronavirus, could spur an immune response. But might it be safer and just as effective to use the RNA that codes for those spike proteins to instruct the patient's body to produce them? And it took a lot of obstacles to surmount to get there over more than 20 years, but we are blown away by how well it works. In parallel, other NIH-supported scientists, including some at our own Vaccine Research Center, learned that locking those spike proteins into the right configuration could make an even better vaccine. So when COVID hit, we knew exactly what to do. But we needed the help of the American people enrolling in clinical trials to finish the job. To facilitate that, NIH opened a dialogue with communities disproportionately affected by COVID to ensure that they had access to the vaccine trials. The Community Engagement Alliance, or CEAL, C-E-A-L, initiative, built on some existing long-term partnerships with trusted leaders in underserved communities to engage directly on trial enrollment, and later with hesitant individuals on issues related to vaccine safety and efficacy. We were able to use the enrollment techniques we learned in the large longitudinal studies, such as All of Us, that you have championed. The result is that all Americans can look at the major vaccine trials and see that people like them were included. While the vaccines were in early trials, the world was clamoring for rapid diagnostics to understand and manage our risks. Members of this committee, most notably Senator Blunt, asked what NIH could do to ramp up innovation. And thanks to your support and using a novel Shark Tank approach, NIH took on a new role as a venture capitalist through the Rapid Acceleration of Diagnostics, or RADx program. Today, there are 33 novel testing platforms helping perform, just today, millions of tests daily due to RADx. This program demonstrated the remarkable innovations that are possible when NIH brings together experts in engineering, business, and manufacturing to fund big ideas. Now the President's budget proposes a major investment to build on this momentum the Advanced Research Projects Agency for Health, or ARPA-H. This new agency within NIH will catalyze novel strategies to speed transformational and innovative ideas. Ideas such as simple blood tests to detect free-floating DNA or protein markers that signal a cancer is growing somewhere in the body. A microneedle patch that delivers a vaccine to hard-to-reach communities in the mail. Using an innovation funnel to recruit, test, and scale up new technologies for ambulatory blood pressure measurement with the potential to transform the management of hypertension. These are just a few of the bold ideas that ARPA-H could tackle, but they are not science fiction. With standard approaches, well, they might happen in a decade or two. With ARPA-H, we believe it could take half that time. The President believes that with your help, we can learn from the lessons of the pandemic and transfer this scientific momentum into big improvements in the health of all Americans. I do too. My colleagues and I would be pleased to answer your questions.
Thank you very much, Director Collins. I have to say I've always loved your success stories. They're usually really beautiful, but I will say I think many of us in this room are grateful to be your success story this time, so thank you. We will now begin our 5-minute rounds of questions, and Dr. Collins, I will start with you. As you just talked about, the President's budget includes $6.5 billion to create the ARPA-H within NIH that is modeled after DARPA. DARPA is a small $3.5 billion agency. It's composed mostly of program managers and empowered to push the limits of their disciplines and shape some milestone-driven breakthrough technologies in short 3 to 5 year stints. Given that the nature of NIH's work is different, relying on a peer review system or multi-year grants that is traditionally risk-adverse, where progress is often measured in decades, how do you envision ARPA-H fitting into the NIH ecosystem?
Senator, it's a great question. I think you are right that much of what NIH does requires this kind of careful, deliberative, investigator-initiated, hypothesis-driven research, and that's going to be the mainstay of what we do going forward. That's been the success story of NIH for many decades. But there are opportunities, as we have seen happening during COVID, such as the need to develop diagnostics in a hurry, to develop vaccines in a hurry, that aren't really amenable to that approach, where you need to have program managers that are empowered to move things swiftly and have the flexibility and the resources to do so. And that is the DARPA model. We've studied that closely, and we do think that there are projects in biomedicine now that would be greatly advantaged by that. That is not the typical peer review process that may take a year from the idea to the first award. With RADx, we made those first awards 5 days after the Congress gave us the budget for it, and that played out really well. So we want to incorporate that mindset, and we want to bring on perhaps 100 of these program managers, give them the opportunity to build the kind of collaborative ventures that include such organizations as small businesses that might otherwise not be likely to write an NIH grant, ride herd over these things carefully so that if they're not doing well, they get basically stopped immediately. We expect there will be failures. This is high risk. But identify the areas of greatest opportunity. And every institute at NIH is now coming forward saying, I've got at least 5 ideas of what I would like to do with ARPA-H that I can't do right now. So this should not be seen as competing with the institutes. It is going to be a synergistic relationship that will allow us to do things otherwise that would take a very long time.
Okay, well, you've said that it should be within the Office of the Director. In that structure, how would decisions be made about what projects to fund?
So we will need to hire a director for ARPA-H who will need to be a visionary person, and the idea is to bring on somebody who's not probably going to be doing this as their long-term career, but maybe for a one-term, 5 years with one possible renewal. That person will be very much engaged then in bringing on board these very creative program managers who have to make a pitch about what kind of projects they think are worth investing in and convince the director that that's the case. And then they are given the flexibilities to go out and find the right partners and see what can happen. But that's all going to be done in a way that's quite nimble. It's not going to involve our traditional peer review process.
Okay. Dr. Perez-Estable, your career is really focused on improving the health of communities of color and underserved populations. And NIH recently released a $30 million funding opportunity to study the impact of structural racism and discrimination in order to promote health equity and eliminate health disparities. Can you talk to us a little bit about what more can NIH and particularly NIMHD be doing to address those issues, and what would be the benefit of making additional investments?
Thank you, Senator Murray, for that question. So first of all, we had to recognize that structural racism could be operationalized as a research construct and not just an organizational construct. And we went through a workshop and scientific reflection on this. I think the moment earlier this year where all of the NIH institutes and centers agreed that this was an area that we needed to move on and advance more quickly in the research side. And so we had a commitment from all the institutes to do this, although NIMHD was leading it from the beginning. We believe that two areas are susceptible for improvement. One would be the healthcare setting, where I think through interventions at the structural as well as the clinician and the patient level will help, and also in promoting healthy communities so that we can have easier access to green space, to healthy food, accessible health care in community health centers. These are two areas that we believe are susceptible for improvement, although we will depend on our scientific community to promote and submit ideas that will be reviewed and hopefully funded within fiscal 22.
Okay, thank you very much. Look forward to working with you and hearing more about that. Senator Blunt.
Thank you, Chairman. Dr. Collins, on the ARPA-H financial request, $6.5 billion. One part of the question would be, how do you think that number was arrived at, and is that a realistic number to commit in year one? And two, our concern would also be that we don't get in a moment. So we've already given NIH $6.5 billion. Let's sort of level fund everything else. I do like the president's $2.5 billion. I'm sure you could figure out how to spend more than that in the other institutes. That's pretty close to the average of the last 6 years from our committee. I'd certainly like to stay at least that level, but how do you think those two numbers compete with each other, and how do you feel about actually being able to commit $6.5 billion in that first fiscal year of ARPA-H?
That's a great question, Senator, and we have thought a lot about it. I am pleased the President's budget proposes that this would be 3-year money, because obviously you're going to start from a standing start whenever the budget actually gets approved for FY22. We hope that'll be September 30th, right? Well, it might not be. So at any rate, we would then really be benefited by being able in that first year to stretch those dollars over a little bit. I do think we could, with 100 program managers, readily come up with the number of projects that would fit within that envelope on an annual basis. But I hear what you're saying about a concern, because I've heard it also, that this might in some way compromise the interests of the institutes. I guess I'd look at it a different way, though. As I said earlier, every one of the institutes is coming forward with great ideas about how they'd like to use ARPA-H. They think of this as an augmentation of their capabilities, not a subtraction. And so they will be feeding ideas into this and have a lot to do about how those are chosen. So even though the base number that's being proposed, $2.5 billion for the ICs, may sound like a sort of average one, in terms of the science they can do, ARPA-H is going to add to that.
All right, thank you. Well, Dr. Sharpless, one of the things the President, of course, talks about in this issue, in this topic, is more rapidly moving toward ending cancer. Obviously, we want to do that. We also want to make the point that that's not the only thing that ARPA-H would be focused on, nor would it just be cancer or Alzheimer's. But on that topic, how do you envision the ARPA-H role in cancer research, and what might you be able to do with ARPA-H that you're not able to do in the traditional restraints of the Institute?
Thank you for the question, Senator Blunt. It's great to be testifying in front of this committee again. Good to see you virtually, at least today. Yeah, as the President has said, ending cancer, as we know it, is a top domestic priority for this administration. Where obviously the Cancer Research Committee is galvanized by this notion and very excited. I think, as you know, the National Cancer Institute does some things really well. You know, we fund basic foundational science very well. We can do clinical trials quite well. But there are some areas where we're challenged, where we have struggles. And I think the scale and nimbleness and the ability to interact with industry is very appealing about ARPA-H for certain kinds of cancer projects. I think a good example of that is this blood-based cancer detector technology that Dr. Collins mentioned in his opening statements, where you can find cancers at a very early stage in otherwise asymptomatic healthy people, and that could have a profound effect on cancer mortality. So, getting up a huge trial of that technology as quickly as possible is the kind of thing that I think would be a good fit for ARPA-H.
Okay. Thank you, Dr. Sharpless. Dr. Tromberg, let me see if I can get one more question in. I think what you were part of at REDX is one of the reasons that gives me real optimism about new kind of relationships that we might develop at ARPA-H. Would you talk just a little bit about REDX and how that partnership continued right through the entire process of these companies that you were choosing to invest money with, going ahead and making the first home-based test, and I think producing well over 2 million tests every day now, in addition to the tests that would have come through the regular process.
Yes, thank you so much, Senator Blunt, and thank you for your question and for your generous support of the RADx program. The bioengineering technology community has formed partnerships all across the government. That's included working with BARDA, FDA, DoD, CDC, HHS, the White House Testing Board. More than 900 scientists are working across government, academia, and the private sector in a very unique way to make this work. And as you've mentioned, if we fast forward to now, about 1 year later, we now have 33 RADx-supported companies that have increased the nation's testing capacity by more than 300 million new tests, and there have been 23 new FDA authorizations. And we've really changed the dialogue from laboratory testing of symptomatic folks to over-the-counter, widely available tests, point-of-care tests that are accessible to all, greater choice and greater capabilities. And this has really happened because of all of these partnerships that we formed, the accelerated innovation. We've brought out new technologies. About 20% of our portfolio, actually, not many people know about, has been based in nanoscience and nanotechnology. Good. So it's been a tremendous surge for innovation.
Thank you, Doctor. Thank you, Chairman.
Senator Reid.
Thank you very much. I want to welcome all the panelists and thank them for their distinguished service to the nation, particularly in this difficult and challenging COVID pandemic. And Dr. Collins, one of the things that's becoming, unfortunately and painfully obvious, is an increase of suicides. And this is very disturbing. And we are concerned also about the impact of COVID-19 on accelerating, perhaps, that phenomenon. So the question I would have is, what research is NIH doing on suicide prevention so that we can recognize warning signs, better communicate to our friends and family, and also give healthcare providers more insights? I'm told that many suicide victims visit emergency rooms frequently before their suicide, and those signs aren't picked up. So your comments would be appreciated.
Well, I appreciate the question, Senator, and it is a source of great concern and obviously great heartache for the way in which this is taking a toll amongst people across our nation, and certainly at a time where mental health issues have been even further heightened by all the stresses of COVID-19. One can see this also becoming even more of a threat to people who have lost hope. NIH is deeply engaged in trying to understand ways to prevent this terrible outcome, and the National Institute of Mental Health has in fact invested in a number of new initiatives as a result of that concern. One that I would point to that has turned out to be a pretty encouraging development is the recognition that the drug ketamine, which is used in anesthesia and sometimes used as a party drug, unfortunately, it also turns out to have benefits for people with serious depression, including people with suicidal ideation. And now approved by FDA in the drug esketamine, this is now available and it is being used in those acute situations of acute suicidal threat. You also mentioned that many people who are on the brink do end up visiting healthcare facilities. We've worked hard to try to make sure that this idea of having a screening tool that was used in emergency rooms for individuals who are there, even if they don't appear to be there for psychiatric reasons, gets used to identify, particularly with adolescents, whether they might be in a situation of contemplating self-harm. On top of that, certainly NIMH investigating other means of treating depression and also thinking hard about other interventions that might be beneficial here in terms of cognitive behavioral therapy combined with pharmacotherapy to try to assist those individuals who are in this difficult place. But it is a terribly difficult problem. I will say it's interesting, but it isn't necessarily that encouraging. The actual suicide rate, as best we know, in the course of the last year has not gone up. It's actually gone down slightly, and that's tended to be the case in national crises before. But what I worry about is what happens when we seem to be getting past the crisis. Is there a a backup there that might, in fact, result in an even greater risk in the coming months? So I'd be glad to give you more information. I'm sure Dr. Gordon would as well, in terms of all the things that we're doing.
Thank you very much. A very quick question to both to Dr. Fauci. The long-haul COVID-19 is beginning to trouble a lot of people. They never seem to be able to recover from it, and recurrences. What attention are we paying to that issue?
Thank you for that question, Senator. We're paying a considerable amount of attention to it. In fact, we have a program to the tune of $1.15 billion looking at developing cohorts of individuals so that we can study them for the incidence, the prevalence, underlying pathogenesis, and if possible, if we can find this out, anything that we can do from an intervention. So the NIH is taking this very seriously. Thank you.
Thank you very much. I have to commend Dr. Sharpless for his efforts on childhood cancer. I was teamed up with Senator Capito. We passed the Childhood Cancer STAR Act. We've been funding it thanks to the chairwoman and at $30 million a year. And I want to commend NIH on its renewed emphasis on childhood cancer, not only treatments, but also gathering data about these victims as they age so that we can see if there's any interventions that we can use later on. So thank you, Dr. Sharpless, and thank you, panelists. Thank you very much.
Thank you. Senator Graham.
Thank you, Madam Chairman. The vaccine, developing the vaccine as fast as we did, what's your biggest takeaway, Dr. Collins? How did we do that? And how can we do it again if we have to?
It's really important to look and see that this was built upon decades of research in basic science that many people might have said wouldn't probably end up being as relevant as it turned out to be.
So all of our money in the past paid off here, right?
Absolutely. This committee and the Congress, especially over the course of the last 6 years, where you have increased the NIH support by 40%, has made it possible for us to do a lot of things that otherwise we'd still not have been able to start. So yeah, it's all built upon that foundation.
Do you feel like the budget request being made is enough to continue to build on what we've done?
I'm very supportive of the President's budget request, as you might expect I would be, and I'm particularly excited about this new proposal of ARPA-H, a new component of NIH that would give us kind of a DARPA attitude that we could bring to projects that are waiting for that kind of opportunity.
Well, I just hope we can memorialize what we did to get the vaccine out so quickly. The developing world, Dr. Fauci, one thing I worry about is getting the vaccine out in the developing world, particularly Africa. What can we do better in that regard? And why should we?
Well, first of all, the answer to your second question, which is very relevant, Senator, is why should we? And the reason we should is that a global pandemic requires a global response. And even though, as you well know from the numbers, we are doing extremely well in this country, we now have over 60% of adults having at least one dose, and about almost 50% of the adult population in this country fully vaccinated. However, even if we get this pandemic under control, which I believe we will within a period of a few months, there is always the danger when you have viral dynamics in other parts of the world for the generation of variants that might actually undermine the protectiveness of the vaccines that we have.
So it's in America's interest to get the vaccine out to as many people as possible.
It is absolutely to our interest. I believe not only do I think it's a humanitarian moral responsibility, but it's in what I call enlightened self-interest for us to do that.
So let's talk about our enlightened self-interest for a moment. Has there ever been a pandemic that we know of that started in a laboratory somewhere?
To our knowledge, no.
Okay. If this were in fact a breach of protocols in China, if it did come out of a lab, that would be a first for the world. Is that right?
I believe so. There was a situation with an influenza where there was a suspicion that it might have escaped from a laboratory in Russia. But that has never been validated or confirmed.
So have we found any animals that carry COVID-19 that could have been the source of the transmission to humans thus far?
Thus far, not. I mean, if what you're referring to, Senator, is an intermediate host,
right?
We know clearly, for example, with SARS-CoV-1, that a bat virus went into a civet cat, which then transmitted it into the human population. With MERS, it was a bat to a camel to human. The intermediate host, if there is one, has not yet been found.
And we've been looking for that intermediate host. Is that fair to say?
That is fair to say, sir.
At what point in time would it become more likely it came from the lab if we don't find an intermediate animal host? How much longer?
I don't think we can give a time element on that, Senator, for the simple reason we still have not yet confirmed what the host is from Ebola. We know that Ebola jumps from an animal reservoir to human, and it's been many years now since the original Ebola outbreaks, and we haven't yet nailed that.
But we believe that Ebola did not come from a lab.
Yes.
Okay.
Yes.
So I guess my point is, who should look? What should we be doing to make sure we find out how it started? Right. And finally, what should be the consequences to any country, China included, that allowed this to happen? What should the world expect of a country if they, in fact, allowed this virus to come from one of their labs through negligence?
Well, first of all, when you said who should, you know, the WHO did what they're referring to now as phase 1 of an investigation, which they felt was not completely adequate. As you know, you've heard me and Dr. Collins and others in the administration calling for a continuation of the investigation. I don't think I can comment on your second question. It would have to be the circumstances under which something like that happened, if indeed it happened.
Well, just very briefly, I know my time's out. I think we should send a clear signal to China, seems to be a source of a lot of pandemics, that if this did occur in the lab, expect something to happen. Because if we don't, we're just going to reinforce this in the future. And what that something is, I'm open-minded to. But I'm closed-minded to the idea of doing nothing.
Thank you. Senator Shaheen.
Thank you, Madam Chairman, and thank you to you, Dr. Collins, and everyone at NIH for all of your hard work over the last very difficult year and for everything else you're doing. As you're aware, diabetes is one of the most expensive and pervasive of our chronic diseases. And I was pleased that in the reauthorization at the end of the year, we funded the special diabetes program for 3 years. And the work that's being done to advance treatment for type 1. But can you talk about this new ARPA-H agency and to what extent it might be looking at ways to help address diabetes?
I would love to, and thank you for the question, Senator. This is the 100th anniversary year of the discovery of insulin. So we've come a long way in those 100 years, but we're not where we really need to be to say we've conquered this one. ARPA-H, because of its ability to tackle problems in a team-oriented, nimble way, offers us some new opportunities here. Certainly one of the ones that the Diabetes Institute has been promoting to me of late, sending me ideas, is to transform the way that we actually develop and test therapeutics. Shouldn't we at this point be able to come up with therapeutics for diabetes that don't require injections? A totally new approach to how we would treat this disease. Another one that I'm excited about, and I know you've done a lot of encouragement about this, is the artificial pancreas.
Right.
And we've made real progress there, Senator, but I think we could go a lot faster if we had this coordinated ARPA-X kind of attitude brought to this, both for artificial pancreases that are built on engineering and sort of a feedback loop that gives insulin when it needs to, but maybe even more so the ones that are built upon the patient's own stem cells that can be converted into that.
And how do we make sure that diabetes is one of those diseases that ARPA-H addresses?
Well, fortunately, because I think we do have a pretty good budget being proposed here, and diabetes is already mentioned by the President as one of the 3 areas of interest, I think diabetes is extremely likely to be on the list.
Good. Thank you. I'm glad to hear that. Dr. Fauci, the question that everybody's asking is, are we going to need a booster shot to complement our COVID vaccination? Do you have any sense of that and what the timing might be for that?
2 parts to that question, and they're separate but important. I don't anticipate that the durability of the vaccine protection is going to be infinite. It's just not.
Right.
So I would imagine we will need at some time a booster. What we're figuring out right now is what that interval is going to be. We know from studies following people from the original clinical trials that the protection goes out at least 6 months and likely a year. But we don't know right now how long that will be. So what we're doing is we're following those cohorts because there's a level of protection that's called a correlative immunity. And we know that if you're above that level, you're in quite good shape to be protected. The vaccine itself gives you a level up here. So how long it takes to start coming back down, we're following it. And 2 ways of understanding that. One, does from a lab standpoint it get below a certain level, or do we start seeing a lot more breakthrough infections? Either of those would be a trigger, but we're following that very carefully. So in answer to your first part of your question, I believe we will need a booster. I'm not exactly sure when.
Thank you. And Dr. Collins, you may remember that New Hampshire is one of the hardest hit states by the substance use disorder epidemic, and we have seen a decline over the last year because of the pandemic, but we've also seen a replacement of many of those opioids by meth. I think there is a belief among some people who use substances that meth can't kill you in the same way that an opioid can. And yet, as I talk to providers, they tell me there are very few treatments that they have available to them to deal with meth. So can you tell me what the National Institute on Drug Abuse is doing to try and address the meth piece of substance misuse?
Absolutely. This is an area of intense interest and concern because what was primarily an opioid crisis is now very much becoming a mixed crisis of opioids and stimulants, and particularly methamphetamine. I was pleased to see that NIDA ran a trial, a phase 3 trial, on treatment for methamphetamine addiction, which is a combination of injectable naltrexone and oral bupropion, and showed benefit. We have not previously had anything to offer to help people who are addicted to meth. That's one step forward. We're also now running this effort to vaccinate people against methamphetamine. I know that sounds odd, but you could immunize against that compound in a way that it would no longer provide anybody much of a benefit if they decided to use it anyway. We're doing that for heroin and fentanyl, and we're doing it for meth.
And excuse me for interrupting, does that work if people have already been users?
It will. So basically getting your immune system to make an antibody so that in the future, if you encounter that drug, it can't get to your brain because the antibodies grab onto it.
I'll have to learn more about that. Thank you. My time is up. Thank you, Madam Chair.
That is very interesting. Thank you. Senator Kennedy.
Thank you, Madam Chairwoman. Dr. Fauci, I believe you have testified that you didn't give any money to the Wuhan lab to conduct gain-of-function research. Is that right?
That is correct.
How do you know they didn't lie to you?
Excuse me, sir?
How do you know they didn't lie to you and use the money for gain-of-function research anyway?
Well, we've seen the results of the experiments that were done and that were published and that The viruses that they studied are on public databases now. So none of that was gain of function. So
How do you know they didn't do the research and not put it on their website?
there's no way of guaranteeing that, but in our experience with grantees, including Chinese grantees, which we've had interactions with for a very long period of time, they're very competent, trustworthy scientists. I'm not talking about anything else in China. I'm talking about the scientists that you would expect that they would abide by the conditions of the grant, which they've done for the years that we've had interactions.
So you don't think the Chinese would lie to you?
Well, when you say the Chinese are a rather broad group. I know the scientists that we've dealt with have been trustworthy.
Mm-hmm. You think all the scientists have told the truth in terms of the origin of the Wuhan virus and not been influenced by the Communist Party of China, do you?
I don't have enough insight into the Communist Party in China to know the interactions between them and the scientists, sir.
Right. Why are we giving them money in the first place?
Well, that's a very good question, and thank you for giving me the opportunity to answer it. Well, SARS-CoV-1 started in China, in Guangdong province, and it went from a bat to a civet cat to a human.
Yes, and excuse me, Doc, for interrupting you, but our time is so limited.
No, I'm going to be real quick.
Our time is so limited. Why are we giving money to the labs in China to study virology?
Well, I'm going to give you a rather succinct answer to that, sir.
I appreciate that.
And that's why I was saying the SARS-CoV-1, clearly the bats that have the viruses, that are the coronaviruses, are in China. As I said a couple of times, it's not in Fairfax County, Virginia, or is it in New York? It's in China. So if you want to show and study, importantly, the animal-human interface.
Because that's where the bats are.
Yeah, the bats.
That's
where the bats are.
I want to be sure I understand your testimony. You didn't give money to the Wuhan lab to do gain-of-function research.
That is correct.
And you believe they didn't do gain-of-function research because they told you they didn't.
We've seen the results of the studies that they conducted, and they were not
including any private studies.
Excuse me? Including?
Any private studies.
I'm not sure what you're getting at, sir.
Here's what I'm getting at. You gave them money and you said, don't do gain-of-function research.
Correct.
And they said, we won't.
Correct.
And you have no way of knowing whether they did or not, except you trust them. Is that right?
Well, we generally always trust the grantee to do what they say, and you look at the results.
Have you ever had a grantee lie to you?
I cannot guarantee that a grantee has not lied to us, because you never know.
Yeah. Can we agree that if you took President Xi Jinping and turned him upside down and shook him, the World Health Organization would fall out of his pocket?
I don't think I can answer that question, sir. I'm sorry.
Well, do you think that the President Xi Jinping has undue influence over the World Health Organization, do you?
I have no way of knowing the influence of the president of China over the WHO.
Okay, so you think the WHO is a completely independent body, level playing field, call it like you see it, and they really want to get to the bottom of the origin of the virus. Do you believe that?
My interaction with the WHO and for Dr. Tedros, the Director General, has been one that I do believe he's a person of high degree of integrity.
I want to ask one last question. Why did you guys spike, not guys and ladies, why did y'all spike the prior administration's investigation into the origins of the coronavirus and whether it could have come out of the Wuhan lab?
Sir, we did not spike anything in the prior administration. I'm not sure what you mean by spike, but we have no influence.
The State Department spiked the prior administration's study.
But that has nothing to do with the National Institutes of Health.
So they didn't consult with y'all?
They did not.
Did they consult with you, Dr. Collins?
I read about it in the press this morning.
Doc? No. They just spiked it without talking to their experts? You don't want to answer that one, do you?
I just read about it.
Thank you, Madam Chair.
Senator Murphy.
Thank you very much, Madam Chair. Listen, the World Health Organization is the most influential global public health institution in the world. Whether my friends like it or not, they have more people and more influence on the ground across the world than anybody else, including the United States. And so if the complaint is that any country, including China, has too much influence, the answer is not for the United States to walk away. The answer is for the United States to double down and make sure that any grievances we have are addressed. Otherwise, the problem for which you're identifying is exacerbated by the United States not being at the table with the WHO. And, well, the major donors to that organization certainly have lots of influence, as is the case with every international organization. It is it is a oversimplification to suggest that they are in the pocket of the Chinese government. China has influence. The United States has influence as well, so long as we are at the table. I have two areas to cover, and the first I wanted to raise with you, Dr. Collins, and that is around the budget request to double the firearm injury and mortality prevention research account. Let me place myself solidly behind that request. Thank you for making it, and I was hoping you might, I apologize if you've gotten a question on this already. I've been listening, but in and out a bit. Hoping that you might be able to talk a little bit about how you might prioritize that additional funding, especially as it might relate to research on community-based interventions and what works and what doesn't, and then, you know, how to make sure that all that information gets out to community partners, folks who are boots on the ground, maybe not the exact set of players that NIH is used to disseminating information to.
Well, I appreciate the question, and we are enthusiastic about expanding our approach and the amount of funds we can put into research on firearm violence. After all, some 40,000 deaths happen each year from firearms. About 60% of those are suicides, which is another topic that came up earlier and is also part of our suicide prevention, is to think about availability of guns. I think you're right, though, that community approaches are very much ripe for this kind of approach, where you might not just try to change one thing in the community, but see if by coordinating the efforts across multiple different ways in terms of making sure that firearms are not accessible to those people who might misuse them, in terms of particularly adolescent and youth risks of violence and how to intervene. Maybe we could take an approach that would be more holistic as opposed to trying to fix one thing at a time. With a larger amount of funding here and a community focus, I think we might be able to do that.
The President has proposed, I think, $5 billion to support these community-based interventions. Maybe some of that will be used for assessment and study, but given the fact that I think we probably can get bipartisan agreement about supporting these investments in prevention, really would be helpful to use some of this increased funding to assess which ones work and which ones don't. Second broad topic, and maybe I'll address this both to Dr. Collins and I think via video Dr. Perez-Stable, is on the topic of social determinants of health. And I'm just interested to hear a little bit about how we've adjusted research based upon our growing understanding that people's health is dictated by where they live and how much money they make and how close they are to pollution sources. My sense is that, you know, this is not an easy sort of thing to incorporate into a research community that is sort of used to working in labs and not always used to thinking about how factors outside the body impact health. What have we learned? How has that changed the way that we fund research and encourage applications to come to NIH that might support social determinant research?
I'm going to ask Dr. Perez-Stable to respond.
Thank you, Dr. Collins, and thank you, Senator Murphy, for that important question. At the National Institute on Minority Health and Health Disparities, and throughout NIH, the topics of social determinants of health have always been present. We consider self-identified race and ethnicity and socioeconomic status, standard measures, to be fundamental factors that influence health in ways that we don't really understand. And that's why we believe that all research with human beings should measure these routinely and follow them. In addition to these two, though, there are other demographic and individual social determinants of health, of which many are issues related to age and gender, sexual orientation, but then structural social determinants of health that you referred to, where one lives, plays, and prays, related to both transportation, housing, and issues around green space, and of course, internet access, which has become incredibly important, as we know, in the last year. So we have these fundamentally incorporated into our standard research, and community engagement is really part of everything that we do at NIMHD and increasingly across the agency.
Well, thank you for that. I appreciate the new focus you're putting on this. Again, this is an area of potential bipartisan agreement. Senator Sullivan and I have legislation in this space and look forward to working with you on it. Thank you, Madam Chair.
Thank you. Senator Shelby, are you ready? You want me to?
Yes, I'm ready.
Okay.
I just got here. Thank you. I've been in another hearing, and this question may have been asked. Dr. Collins, it's always good to see you.
Likewise.
I agree with a lot of people on this committee that the money we put in to biomedical research benefits mankind, period. Not just our people, but the world. What are the top 2 or 3 promising areas of biomedical research in the area of autoimmune? That's a big, big topic. You know it better than anybody. What are the breakthroughs there, the hopes in 2 or 3 of those top areas?
Well, thank you, Senator. It's good to see you, and I know you're running from one place to another. I'm glad you're here. I just had a wonderful experience yesterday afternoon listening to presentations from a consortium of researchers that we have funded jointly with industry. So this is called the Accelerating Medicines Partnership, and it's focused on rheumatoid arthritis and lupus. And what they have done is to take this field, which was looking at immunology in a way that was pretty cutting edge 5 years ago, and now completely transformed it by looking at individual immune cells in the synovium of people with rheumatoid arthritis, lining the joint, and say, what are you doing there, immune cells, and how does that teach us what the real pathogenesis is about? And for lupus, they're looking at kidney biopsies, because, of course, lupus affects the kidney, and that's one of its serious consequences. Same thing, looking at individual cells. It has completely revamped our understanding of these diseases. We have learned, for instance, that the parasite, which was just sort of a cell that we thought was hanging out watching in the kidney of somebody with lupus, might be the driver of what's really happening there as far as the immune response. This is not P-A-R-A, this is P-E-R-I site, in case that's not clear. For rheumatoid arthritis, it's the fibroblast. And we are so excited about this. We're now planning to expand that same approach to other autoimmune diseases, to psoriasis, to psoriatic arthritis, to Sjogren's syndrome, and maybe others as well. So you hit me at a great moment. I was so jazzed yesterday to see what's been possible.
It's all based on bacteria, isn't it?
It's all based on this ability to look at single cells, one at a time. We haven't really been able to do that until about 5 years ago. We'd have to look at thousands of cells and try to infer what was there. And now you can ask each one. And the cell is, after all, the basic unit of all life. And it's been outside of our reach, but not anymore.
What could that do for the autoimmune area?
I think it could have a huge impact because we now have new targets coming out of this recognition that I think in the next 4 or 5 years, we're going to see a whole new generation of drugs for autoimmune diseases based upon that insight that's just now emerging.
I've brought this up many a time, but in the area of cystic fibrosis, there have been so many breakthroughs in that area, extended children's life, adults' lives, and everything. Where are we going there? We've come a long way, but we're not there yet.
We're not completely there, but oh boy, have we come a long way, especially in the last 2 years now with this 30-year effort, and I've been deeply engaged in this, having had a role in discovering the gene back in 1989. And now we have this triple drug therapy, which for 90% of patients with cystic fibrosis is dramatically beneficial. I get messages almost every week from somebody who was really in tough shape and now they're back at work, or somebody who was on a transplant list and now they are taken off of it because their lungs are doing so much better. But there's still that 10%. This is where I think the gene editing approach, where you actually figure out how to fix that misspelling of the cystic fibrosis gene in the lungs of somebody who's affected, might be the way to get to 100%. And there's a lot of work going on that.
What promises are out there that you've talked about before dealing with lupus, which is an autoimmune disease?
Well, as I mentioned, we have this ability now to be able to see individual immune cells. What are they up to in lupus, both in the kidney and in other areas as well? I think that is teaching us some new things about what the real fundamental cause is. And it will tell us that some of the treatments we've been giving, like steroids, are kind of a little bit too much of a sledgehammer. And what we need now is something much more subtle to go after the fundamental problem. We got a better chance at that now.
What about the area of pancreatic cancer? That's a fast-moving thing, I know.
It is indeed, and if Dr. Sharpless is listening, maybe he'd like to quickly give a response since that's his area, the Cancer Institute. Ned, are you there?
Sure, yeah. Thank you, Francis. Pancreatic cancer is an area where we haven't seen the success that we've seen in other cancers, but it's not for lack of good ideas. So there are one of the realizations is that pancreatic cancer comes in lots of flavors, and each one needs its own treatment. So now we're working on this subset approach to pancreatic cancer. I think there's also a real opportunity to detect pancreatic cancer earlier and at a more curable stage. So I think those are the exciting areas of pancreatic cancer research.
Thank you. I'd like to get in, I know my time's moving on, the chairperson has been very kind. Dr. Collins, in the area of the CTSA program, the Clinical and Translational Science Award program, the CTSA hubs and their partners, I think, have done a lot of good work in that area, valuable work, especially during the COVID-19 thing. It's my understanding that the NIH, National Institutes of Health, that you had, is considering significant changes to that program that would discourage hubs like UAB, for example, in Birmingham, from forming partnerships with certain non-clinical universities and research questions. Is this true, and why is that?
That is not a correct assumption. I know there are some rumors flying around about that, and there will be a public announcement about this. Basically, just without trying to get too far ahead of what hasn't been revealed publicly, I think we're trying to simplify the application process to make it easier for those hubs, and we intend to keep them going in vigorous ways to apply when they're up for renewal in a way that doesn't require an application of 2,000 pages, which is what it has been. But we would not want to do anything to discourage these collaborations that you're mentioning. Take that from me.
Thank you. Madam Chairman, thank you.
Thank you. Senator Manchin.
Thank you, Madam Chairman, and thank all of our presenters. I appreciate very much them being here. My first question would go to Dr. Fauci. The Food and Drug Administration reports that nearly 40% of finished drugs and roughly 80% of active pharmaceutical ingredients are manufactured abroad. During the COVID-19 pandemic, we saw factories shut down in order to prevent spread of virus, drug supply chains disrupted, and drug shortages increased. As a result, America's access to essential medicines was really put into jeopardy. As a preeminent infectious disease doctor, you know better than anyone how important it is to have access to essential medicine. So my question would be, Doctor, can you comment on the importance of a strong domestic supply chain for essential medicines, and how can we ensure we don't experience future drug shortages when the global supply chains are disrupted?
Thank you very much for that question, Senator Manchin. I think it's absolutely critical that we have the capability, independent of supplies from foreign countries, to be able to supply the necessary medicines that we need in the United States. I have been of that opinion for a very long period of time. The solution to the problem is to be doing much less of the outsourcing to foreign countries for the important ingredients of many of our medications. So right now we are not in that good position, and I believe, particularly since the disruptions of the supply chain that have occurred with the COVID-19 pandemic, that this might be a good lesson for us for the future to make sure we have much more dependency on what we can do domestically as opposed to in foreign nations.
Doctor, have you all looked at why is most of manufacturing left the United States, and why are we not able to manufacture, or are we at a disadvantage in the United States for other reasons, cost-wise, or basically different types of things that we make people jump through hoops and everything else as far as permitting and all that? What would be the cause?
You know, Senator, to be honest with you, I don't know why that's happened. I think it was because it was felt it would be much less expensive to get this done outside. But I don't really know the answer to your question of why we have so much of a dependency of important materials outside of the country. But certainly, whatever the reason, I believe it needs to be corrected.
Well, I need to work with you on that, Doctor, if I can, basically, in making sure this administration, I think they understand the urgency we need to start basically manufacturing again, not only just our drugs, but so many things in our country. So I look forward to your support on that. Dr. Collins, West Virginia is constantly ranked last in the nation for health outcomes. In 2020, the America's Health Rankings reported ranked my state of West Virginia 50th for premature deaths, frequent mental distress, and multiple chronic conditions. We also ranked last in life expectancy. What is the NIH doing to bridge this gap in health outcomes, and how do you ensure that the medical research that you do benefits people in poor rural communities?
Well, it is very troubling to see the fact that you've just cited, that health outcomes are not what we would all want them to be. And of course, there are many factors that play into that, Senator, and we're deeply engaged in research and trying to identify the ones that are addressable. Certainly one of the things I might point to is the increasing focus we have on disease prevention. If we simply are limiting ourselves to trying to help people who've already developed a serious disease, we've kind of missed the opportunity. Unfortunately, our healthcare system doesn't do a great job in that situation of providing support for disease prevention, and it seems happier to pay for things once people are already quite ill, so there's additional work that needs to be done there. One of the things that I think I'd point to is a series of large-scale efforts to really understand what are the factors that play out in people staying healthy or getting a chronic disease, or how you manage that. The All of Us program, which this Congress has supported, on the way to enrolling 1 million participants, including in West Virginia, is a way in which we can collect that kind of evidence, including their electronic health records and lots of information about their environmental exposures, and try to figure out in a holistic way, how can we take that information and bring forward a better chance for people to live not just a good lifespan, but a good health span. So we're deeply engaged.
Thank you, sir. Dr. Fauci, finally. You know, my home state of West Virginia is battling an epidemic during the middle of a pandemic. We've been devastated by the drug epidemic, COVID-19, and we now lead the nation in new HIV infection rates. You spent much of your career focused on prevention, diagnosis, and treatment of HIV/AIDS, and your research has been instrumental in saving countless lives in the United States and around the world. So, Doctor, what is being done to replicate testing and surveillance efforts we saw put into place for COVID-19 for other infectious disease like HIV/AIDS? And what public health infrastructure would be required to bring better infectious disease testing and surveillance to fruition?
Thank you for that question, Senator. The HIV testing situation, unfortunately, has been somewhat interrupted by the COVID-19 pandemic because of the interruption of multiple services. But as you know, we have a 10-year plan to end HIV as an epidemic in the United States, and that is going to require access to testing for those who are not infected, to put them on if they're at risk to pre-exposure prophylaxis, and those who are infected to immediately put them on antiretroviral therapy, because as we know, when you bring the level of virus to below detectable, not only do you save the life of the individual, but you make it essentially impossible for that individual to infect someone else. So testing is really at the fundamental basis of how you address the epidemic, and for that reason, it's going to be extremely important to get our testing capabilities back up to snuff once we get the country back on a degree of normality following control of the COVID-19 pandemic.
Thank you. Thank you, Madam Chairman.
Thank you. Senator Braun.
Thank you, Madam Chair. Dr. Fauci, I was listening with interest in Senator Kennedy's line of questioning, which probably was asking you to maybe answer some things based upon what the WHO should do or not. I'd like to discuss something that's probably a little simpler to answer in terms of transparency in general. From the time I've known you and Dr. Collins has generally been in this seat, and we've been talking about something related to COVID. Would you agree that in the whole process of now that there are second thoughts on how this thing derived, that it may have come from a lab, that we should emphasize as much transparency as possible in pursuit of getting the answer?
Without a doubt, Senator, no doubt.
And then the next logical question would be that we don't know what we're going to get from the communist regime or the WHO, but we do know that through our Director of National Intelligence and probably DHS from Haynes and Mayorkas, that they probably got information there. And so since you believe in transparency, wouldn't you think that we should declassify all the information that we own so that you, Americans, independent researchers, can see what we've got to sort through how this thing started?
Well, Senator, I have said publicly and most recently that I believe that there should be transparency and open, fair, and independent continue to look. As I've said, I still believe that the most likely scenario is that this was a natural occurrence, but no one knows that 100% for sure. And since there's a lot of concern, a lot of speculation, and since no one absolutely knows that, I believe we do need the kind of investigation where there's open transparency and all the information that's available to be made available to scrutinize.
So since you've been the point person on just a variety of topics through the COVID saga, does that mean then you will ask President Biden to declassify that information?
I don't think I can promise you.
But I mean, would you ask him, since you believe in transparency, wouldn't it make sense that we get the information that we have? And I think if it doesn't come from you, Dr. Collins, someone that's been in the mix from the get-go, that we won't see it. And we owe it to the American people with what we've been through to at least look at the information that we have.
Yeah, I'm not sure the information we have, but I'm not sure if it's my place to tell the President of the United States to
But you've been very engaging on a wide range of topics, and I think he'd respect your opinion as much as anyone. Dr. Collins, where are you at on that subject of giving the American people the information that we house?
Well, I'm very much where Dr. Fauci is, with the desire to be as transparent as possible in this situation and really try to find out what happened. I agree with him that it is most likely that this is a virus that arose naturally, but we cannot exclude the possibility of some kind of a lab accident. That's why we've advocated very strongly that WHO needs to go back and try again after the first phase of their investigation really satisfied nobody. And this time we need a really expert-driven, no-holds-barred collection of information, which is how we're mostly really going to find out what happened. I'm just not in a position to know what might be in the classified documents and what else might be there that would not be relevant to this and might actually be harmful to national security. I take your point, but I know the President is very interested also in seeing truth come out here, so it may not require Tony or me to tell him that this would be good to make this as visible as possible.
Well, I think for the American public, if we're relying on the WHO to do it again, even though it seems like they've had somewhat of an epiphany that we need to dig deeper, I think if it doesn't come from the two of you to ask for simply the release of information, of course, keeping hidden anything that would be something that could not be exposed, but I'm guessing there's a good bulk of that that would be benign in terms of just the information we have about the origin of the disease. So I think for many of us, many Americans, with what we've gone through, we ought to at least be willing to look at the information that we have to get people satisfied that we're getting to the bottom of it. So I'd ask each one of you to think about that and see if it makes sense. Have our president declassify it so we can see it.
Thank you.
Thank you.
Thank you. Senator Moran.
Chairman, thank you. Dr. Collins, well, doctors, welcome. Good to be here with you, and I appreciate your presence and your work. Let me talk about clinical and translational science, if I could. Under Dr. Austin's prior leadership, the National Center for Advancing Translational Science at NIH has been essential in facilitating clinical and translational research, and I've seen it in Kansas. In fact, I've seen it with the director of that directorate. In Kansas, NCATS Clinical and Translational Science Award Program has served for a catalyst to bring lots of organizations in the research community and community partners together to advance research. I have concerns with potential changes that are under consideration for the CTSA program, in particular changes that would lower hub awards and limit CTSA partners. Moving forward, will there continue to be consideration for ensuring that CTSA centers are located in regions in the U.S. which do not already have those hubs? There is already a limited number in the Midwest, and I'd be concerned if any changes to the program that would make it more difficult for these hubs to compete. And then I'd ask the question about partners. At the University of Kansas, for example, they partner with Children's Mercy, Kansas City University of Medicine and Biosciences, Kansas State University, St. Luke's Health, University of Kansas Health System, KU Office of Research, KU School of Medicine in Wichita, University of Missouri in Kansas City. Since the CTSA program is focused on partnerships between regional research hubs and community partners, why would NCATS limit the ability of the program, in my view, to accomplish its goal?
Well, Senator, thank you for the question. I'm a big fan of the CTSA program and enjoyed my opportunity to travel to Kansas with you and see some of the things they were doing a few years ago. And this is, I think, one of those circumstances where there seems to be some anxiety in the CTSA community about something that hasn't actually been announced yet. And I would like to be reassuring about this. The real intention of the change that's being proposed is to decomplicate the renewal process, which currently requires an application of about 2,000 pages that I don't think anybody enjoys putting together, and to try to make this more straightforward. There is no intention to reduce the number of hubs. Certainly every hub has to compete to show that they're actually using the funds wisely, and we will continue that process. And this notion that somehow the new process will discourage collaborations with other institutions, I find a little hard to understand, because I have no knowledge that that's at all intended to be the case, and I would personally oppose that.
Thank you for your reassurance. My question was more complicated than I wanted it to be, but your answer was very comforting. Let me ask just a couple of specific questions. What can this committee do to support NCATS efforts to enable and facilitate advanced important research in rare diseases for patients living particularly in rural communities?
Well, NCATS is deeply engaged in rare diseases. Our former director, Chris Austin, not only was a personal promoter of that, he was the head of the International Committee for Rare Diseases, and that tradition will continue under acting director, Dr. Rutter. Certainly the support that this committee has provided to NCATS to make it possible for that kind of investment to happen in rare diseases for which companies probably aren't going to make an investment because the market is too small is one of the reasons that we've now made really significant progress in dozens of these rare diseases. We are also engaged right now in a serious conversation with industry about whether there's a way, with gene therapy emerging as an even more attractive opportunity for rare diseases, to make sure that we move that forward at all due speed and not have it held up by such things as a limitation in manufacturing of viral vectors. So they're right in the middle of that, and the support that you all have provided has made that possible, particularly through the Cures Acceleration Network, which is part of NCATS.
Can one of the directors talk about the improved science, this additional investment in Alzheimer's research will help fund, including a better understanding of risk and protective factors in individuals, again, perhaps with a focus on rural populations?
That's probably me, because Dr. Hodes is not here. So, yes, this committee, this Congress, has increased funding for Alzheimer's research by 5-fold over the course of the last 7 or 8 years. And that has made possible all kinds of bold approaches we otherwise wouldn't have had. We now have dozens of new drug targets that have emerged from the very careful analysis of who gets Alzheimer's and who doesn't. Of course, we're all waiting to see what happens in maybe next month when FDA makes a review decision about the monoclonal antibody from Biogen, aducanumab, and that'll make a big difference if they decide there's something there. But we're not depending on that. So yes, and I might add this ARPA-H proposal, which is part of the president's budget, specifically calls out Alzheimer's as an area of great opportunity to do some of these very bold, aggressive, and nimble approaches that would probably not happen so easily by our standard grant mechanism.
Dr. Collins, I was confused by what I thought was all the directors were appearing, although just not all of them in person. But thank you. You can pitch hit for each and every one of them, and you did it again.
I'll try.
This morning. I'm going to see if I can get Dr. Sharpless to come to Kansas and join us again in a visit.
Well, he's listening, so he heard you.
Oh, I look forward to that.
All right. Consider yourself invited, and I consider you just accepted.
Thank you.
Senator Schatz.
Thank you, Chair Murray, Ranking Member. Dr. Collins, in 2019, I wrote to you and the then FDA Commissioner requesting an update on efforts by NIH and FDA to research psychedelic drugs to treat mental health illnesses. Since then, there have been a number of potentially promising peer-reviewed clinical research on this topic. Can you give me an update on what the next steps may be?
I appreciate the question. Yes, there has been a resurgence, I think, of interest in psychedelic drugs, which for a while were sort of considered like not an area that researchers legitimately ought to go after. And I think as we've learned more about how the brain works, we've begun to realize that these are potential tools for research purposes and might be clinically beneficial. I'll just mention one, which is psilocybin, which has now been tried in no less than 3 randomized controlled trials for depression and is showing a signal there of potential interest. And that could be quite exciting because we all are looking for new approaches to that. But there are other trials going on with MDMA, even with LSD. I think at the moment it's the psilocybin that's gotten the greatest attention.
And what are your next steps?
I've been talking with the Drug Abuse Institute, and I'm sorry they're not here, and the Mental Health Institute, and they're not here, so I'm pinch hitting for them as well, about whether it's a good moment to consider having perhaps a workshop to say, okay, what have we learned so far, and what more might we want to do as far as designing the next generation of clinical trials to see where these provide benefit, going beyond depression to such things as PTSD. So I think over the course of the next year, we're going to want to have a hard look at this.
Thank you. In 2019, you wrote to me that the NIH is committed to advancing research on the risks and potential benefits of marijuana for therapeutic uses. In that letter, you cited a number of barriers to advancing this type of research. Are we making any progress?
We're making some progress. You may know that in the past, researchers who wanted to do a clinical study on marijuana had all kinds of limitations. It took generally at least a year to get through the process of paperwork to be allowed to utilize marijuana because it's a Schedule I agent. But it was also an issue as there were only one source, which was our marijuana farm in Mississippi. When I became NIH director, I was told, hey, you're running a marijuana farm. Who knew? And that, of course, is an issue because it's a limited opportunity for access. DEA has now given permission to expand the number of suppliers. That will help. But frankly, what we really need is to moderate this Schedule I limitation. Dr. Volkoff and I have been proposing for a while something called Schedule 1R, which would be basically a different pathway if you're going to use this material for research.
So I have a bill with Senators Feinstein and Grassley, which passed the Senate, did not pass the House, to address some of these barriers. Do I have your commitment to work with my office on this legislation?
I'd be glad to.
Thank you. I want to talk to you finally about chronic pain and non-opioid alternatives. I've passed a couple of laws in this area to enable research, and I think when people think about alternatives to opioids, they move right in their mind, they move right into alternative medicine. And what I'm talking about is a non-opioid pharmaceutical solution to chronic pain. And I'm wondering whether we're making progress in that space, because certainly if people find other ways to alleviate their pain, physical therapy, yoga, whatever, mindfulness, I'm for all of it. But there's still a space here for a pill that you can take to alleviate chronic pain without getting you hooked on an opioid. And where are we with this?
That's a critical issue, and this Congress has supported NIH in something we call the HEAL Initiative, which stands for Helping End Addiction Long Term. Part of that is about how to better treat people who are addicted to opioids, but a big part of it is to coming up with alternatives for chronic pain management that are not addictive, that are not opioids. As a result of that, we have partnered up with industry to basically identify promising therapeutics that attack different targets in the pain mechanism that might therefore be beneficial, such things as a sodium channel, for instance, called NaV1.7 that's involved in the pain transmission. But if you block that, it should not give you any risk of addiction. We're making real progress there. We have something called EPIC-NET, which is bringing on board promising compounds, getting them into phase 2 trials as part of the HEAL initiative. I could give you a lot more information about that if you'd like.
Thank you. And I'll just submit this one that you can consider for the record. The U.S. has the same federal trust responsibility for Native Hawaiians as it applies to Alaska Natives and American Indians. And I'm hoping that you will consider expanding the scope of the Tribal Health Research Office to include Native Hawaiians. I'll get you a more full question for the record and look forward to your response. Thank you.
Glad to look at that.
Thank you. Senator Hyde-Smith.
Thank you, Madam Chairman. Thank you for holding the hearing, and thanks to all the witnesses that are participating today, and I certainly appreciate your willingness to serve. That is not lost here for sure with the past year that we've had. Dr. Collins, I wrote to you last November to express my concerns that projects recently funded by NIH disregard the spirit long-established policies against creation of a federal firearms registry, and particularly an NIH grant to Northwell Health of New York provided federal funds for the hospital to ask the questions about lawful gun ownership of every patient seeking health care for any reason whatsoever at the hospital's emergency department. Even more concerning, every member of the advisory committee overseeing the grant has been very outspoken advocates for expansive gun control, including bans on large classes of common and popular firearms. I have long been concerned about how firearm registries can undermine the ability of law-abiding citizens to exercise their Second Amendment rights, and several provisions of federal law already prohibit data collection related to lawful gun ownership, and I have introduced legislation to strengthen these provisions even further. Dr. Collins, given that President Biden is seeking increased funding for grants like the one awarded to Northwell, how are you making sure that such projects do not infringe on Americans' constitutional gun rights or violate federal statutory prohibitions on gun registries as they stand right now?
Well, Senator, I recall your letter, and we looked closely at that particular grant from Northwell and what they were proposing to do. First of all, I think we can all agree that gun violence, which takes about 40,000 lives every year, is something that does deserve close attention and scrutiny as far as the research that we might be able to do to understand what are the causes and how to save those lives if it's possible to do so. So we will actually be glad to pursue those opportunities. But we're mindful of the prohibition that Congress has put forward many years ago about not advocating for gun control, and we've been pretty careful about that. I think in that instance, the particular grant, while you are right that they were asking for this information, it fell somewhat short of what most people would have called a broad concept of a gun registry. And I think that's, if I remember, what we said in the letter in response to you. But I want to promise you we are going to be very sensitive to those issues as we now, with the President's budget, seek to see if we could do more to try to identify reasons that gun violence is so prominent and what research might teach us about how to save lives.
Thank you. I appreciate your consciousness of that and being in that position. And this question may have been asked before. I've been in another hearing. I hope I'm not being redundant. But like many of my colleagues, I firmly believe we need to get to the bottom of the origin of COVID-19. And this seems even more important after this week's Wall Street Journal report that 3 researchers from China's Wuhan Institute of Virology sought hospital care in November 2019 for symptoms consistent with COVID-19. First, I want to go down the line for all of our witnesses of how strongly do you believe that it is possible that the origin of COVID-19 pandemic resulted from a leak of the virus from the Chinese lab? And second, Dr. Fauci, I would like to ask you specifically is how is your institute working to get to the bottom of the origins of COVID-19, including exploring the leak theory. So I'm going to start with the entire panel for the first question of how strongly you believe that this is possible.
Well, I'll start, and then others can respond. Again, I will say I think the most likely mechanism by which SARS-CoV-2 arose was a natural process of transfer from an animal to humans, but it is certainly possible that other options might have occurred, including a possible lab leak. We just don't have evidence to be able to say what that likelihood is. Dr. Bianchi.
Yes, so I would agree with Dr. Collins. We have no personal knowledge of anything that might have happened in China at the National Institute of Child Health and Human Development, but we fully support a full investigation of getting at the facts.
Dr. Gibbons. Dr. Gibbons, are you there?
Yes, I concur with my colleagues in terms of transparency is a critical part of this.
Dr. Sharpless, I think I saw you on the screen.
Sure. Yes, Senator Heitzman, I saw the same report. I found that concerning. I think lab accidents happen, and we need to investigate the possibility, although I think many of us feel zoonotic transfer is perhaps more likely. I think we should investigate all possible explanations.
Dr. Perez-Stable.
I concur with my colleagues. I think of concern, but certainly we need evidence.
And Dr. Tromberg.
Yes, I agree with my colleagues as well and would like to see more investigation.
Dr. Fauci.
Yes, as I've said many times, I feel the likelihood is still high that this is a natural occurrence, but since we cannot know 100% whether it is or is not, other possibilities exist, and for that reason, I and my colleagues have been saying that we're very much in favor of a further investigation to the next phase from the WHO, who has already done a phase 1, and we're strongly in support of continuing that to a phase 2 investigation.
Thank you very much, and I yield my time.
Thank you so much. Senator Baldwin.
Thank you, Madam Chair. Last week, I had the privilege of joining some of my colleagues on a visit to the National Institutes of Health. While much of our discussion was centered on the response to the COVID-19 pandemic, I was struck by the broad applications of the innovation that we have seen during this time. And I've often spoken about the Wisconsin-based company FluGen, which is working to make vaccines that can be administered as a nasal spray. I also believe that this type of innovation is key in the terms of how we think about our ability to respond to future pandemics. Dr. Tromberg, it was great to see you on that trip to NIH. I wonder if you could describe how engineering advancements have contributed to our response to COVID-19, and how are you thinking about the future of delivery and administration of vaccines and therapeutics, and how will these advancements help us prepare for the future?
Thank you, Senator Baldwin, for the question, and it was great to meet you last week, or I guess it was 2 weeks ago when you came to visit. So for COVID, we've supported a wide range of technologic advances in medical imaging and artificial intelligence, digital health platforms, PPE, ventilators, new therapeutic approaches. Of course, the biggest, probably and most impactful has been the RADx testing program, which has delivered, as you've seen, more than 300 million tests, including over-the-counter tests with very advanced technologies from nanoscience. In terms of vaccines, this is a very exciting area, another one that we've had in our portfolio. One of the strategies that we have been supporting are microneedle patches. So imagine a dime-sized microneedle patch that is got, the needles are entirely soluble in water, and as soon as you put them into your skin, they start to deliver the vaccine. After the delivery, the needles are all gone and you throw the patch away, you get a new one in the mail. So this has moved into phase 1 clinical trials. Efficacy has been shown. I might, if you have a moment, toss it over to Dr. Fauci, because we have collaborated with his institute in the development of these new delivery approaches, and they may have some other approaches as well.
Please, Dr. Fauci.
Thank you, Bruce. Yes, we have an active collaboration with Dr. Tromberg's institute, and we're looking towards the future about how we can make it much easier to get people vaccinated. This is of particular relevance right now because with COVID-19, even though we're doing really very well with vaccination, we still have a group of individuals who were really difficult to get to, and hopefully when we have a much easier way to administer, the way Dr. Trumberg has mentioned, that will make it easier for us.
Excellent. In April, the University of Wisconsin launched the Center for Health Disparities Research. The center, which has a leadership team comprised entirely of women, will focus on how physical environment and social conditions intersect to influence an individual's health. Their first initiative, funded by the NIH, will use data from 22 Alzheimer's disease research centers throughout the U.S. to examine how social determinants of health throughout a person's lifetime impact their brain health. The pandemic has made it clear that we need to do more research like this to better understand and respond to health inequities. And I applaud the work of Dr. Amy Kind and the University of Wisconsin. But it's imperative that we maintain our commitment to this into the future. Dr. Perez-Stable, how has the impact of the COVID-19 pandemic on communities of color informed how NIH thinks about studying health disparities going forward? And what additional investments are needed to fill these gaps?
Thank you, Senator Bowen, for that question. I think a year ago, when we understood the dimension of the dramatic disproportionate burden by race, ethnicity, and socioeconomic status on the population, there was a sort of an aha moment for all of NIH to say, this problem has been with us for a long time. We have made limited progress. It's time we put our innovation, our efforts to address this. Out of this effort, we created the Community Engage Alliance Against COVID-19. Dr. Gibbons and I are co-chairing that. Dr. Collins mentioned it in his opening statement. And I think to heighten the importance of community engagement, so talk to the people that are affected, bring them in as full partners, identify the problems, and then mobilize all sectors that we can mobilize, not just the researchers and the healthcare clinicians, but also the housing, transportation, zoning, all the different sectors of society to see how we can begin to make a difference in this setting. And I applaud the effort of Dr. Kind. She was a grantee of ours, as well as others, and also applaud the effort of looking at existing data with standardized measures to address problems of this kind, like Alzheimer's disease.
Yeah. Thank you so much, Madam Chair. I yield back.
Thank you. Senator Rubio.
Thanks to all of you for being here. I think I'll direct this to Dr. Fauci, but I welcome everybody's answer. I just want to go through what we do know. We've heard a lot about what we don't know. So here are the things that we do know, okay? So SARS-1, we identified the host animal within 4 months. MERS, I believe we identified the host animal within 9 months. It's now been 15 and a half, 16 months. We've still not seen, and China's not produced any evidence of the host animal that transmitted COVID-19 to a human. We know that China has a history of lab accidents. I think, Dr. Fauci, you answered Senator Graham's question. I think he phrased it as, has there ever been a pandemic that came out of a laboratory? And the answer was no. But we do know of outbreaks that came out of a laboratory. I believe back in 2004, 2 researchers in Beijing were infected doing research on SARS and led to an outbreak. China has a history of lab accidents. This outbreak happened in a city that happened to be the home, coincidentally, of a lab which we know is involved in extensive research. And what they do is they take this naturally occurring virus and they manipulate it and they change it to make it infectious to humans. We know that they do that there. They've published about it. And it also happened in a city, in a lab, where a Rutgers biosecurity expert raised concerns about its safety. And our diplomats in 2018 were cabling back to Washington expressing concern about the safety. So I take all those facts together, right? SARS, we knew the host in 4 months. MERS, we knew the host in 9. We still don't know the host for COVID, even though, and China's not being transparent about it, even though they have a vested interest in producing the host, so they can put all those down. In a lab that we know is involved in changing viruses synthetically so that they become infectious for humans. in a lab that diplomats have told us is unsafe, in a country that had a history of lab leaks, and by the way, in a virus that we know can be synthetically created because the Swiss did it. The Swiss created an exact replica of this virus in the lab for purposes of answering it. All of these facts were available to us last April. Why, I'll start with Dr. Fauci. Why did you dismiss the lab leak theory as credible?
I have always said that the high likelihood is that this is a natural occurrence. I didn't dismiss anything. I just said it's a high likelihood that this is a natural occurrence from the environment of an animal reservoir that we have not yet identified. Well, and I still maintain that, but as I just mentioned to the response to other questions, that since you don't know 100% about that, because no one knows, including me, 100% what the origin is the reason why we're in favor of further investigation.
Well, given everything I've just cited, and if anything I just cited is incorrect, I hope it'll be correct that I'm relying, obviously it's not my field of study, so I'm relying on what other experts have published. What is the basis for this what is the basis for the conclusion that it is likelier to have been naturally occurring than a lab accident? I asked a specific question to the Director of National Intelligence, and how I posed it is it not true that it is the assessment that they are equally likely based on our information that we have? So as I outline all of these things here, is she wrong when she answered me yes? And based on everything I've just cited, what is it that we're basing the higher likelihood of naturally occurring? Is it simply because that's all we've ever seen in the past?
Well, we have historical experience that happened with SARS-CoV-1. It happened with MERS. It happened with HIV. It happened with virtually all the influenza pandemics. So the historical basis for pandemics evolving naturally from an animal reservoir is extremely strong. And it's for that reason that we felt that something similar like this has a much higher likelihood. But again, getting back to what I said, and let me repeat so there's no lack of clarity in that, no one knows, not even I, 100% at this point, which is the reason why we are in favor of further investigation.
But going back to precedent, the precedents require them to be similar. The difference between this one and that one is, as I said, 4 months we knew the host for SARS, 9 months we knew the host for MERS. China has all the incentive in the world to produce this host and hasn't done so. And then you add up all these other things. I mean, is it just a coincidence it happened in the city that's doing this kind of research, which, by the way, is controversial? I know you know have been supportive of it, but it's controversial. It's not widely accepted as good. My whole point is there are people out there who had Facebook posts taken down, were called kooks, conspiracy theorists, for saying publicly a year ago what we now say may be possible. And I think those people deserve an apology at a minimum. Thank you.
Thank you. Dr. Bianchi, thank you. NICHD is trying to develop ways to identify children at high risk for multisystem inflammatory syndrome in children. It's a rare and life-threatening after effect of COVID-19. Now, while most children who become infected, I know, have mild or no symptoms, some do go on to develop this severe and sometimes fatal condition. I know your research is still in the early ages, but could you describe the NICHD's efforts to develop clinical predictive models using machine learning to identify children at risk and how physicians are using this testing device and data?
Thank you very much for your question, Senator Murray. As you know, there are almost 4 million children who have been infected with SARS-CoV-2. But the key is to figure out which is the 1 in 1,000 child who is going to get very sick with this MIS-C, and that child could get critically ill, although most do recover. So as a parent, you'd want to know if my child tests positive, what's going to happen. And so as part of the RADx-RAD program, NIH is supporting this 4 different programs caring for children with COVID, but the predictive one that is using artificial intelligence and machine learning is called the Prevail Kids program. And what that is it's 8 different programs around the country with some international partners that are using existing cohorts as well as prospectively enrolled cohorts to collect biospecimens and use artificial intelligence in conjunction with the electronic health records. The program started within the past few months, so we don't have evidence yet, but the enrollments are on target, and we are expecting to enroll about 12,000. Actually, we've already enrolled about 12,000 children out of 16,000 that are expected.
Okay. And Dr. Sharpless, artificial intelligence has been shown to help improve the detection of breast cancer in mammograms and lung cancer and CT scans, and suggesting that AI appears well suited for imaging. Are you looking at the potential for AI to help early detection of other cancers?
Oh, yes. This is a very important topic. I think artificial intelligence has really the ability to transform cancer research and cancer clinical care in dramatic ways. We have a very lively set of collaborations going on with the Department of Energy that has extensive expertise in this topic, to use AI to try and identify drug targets for medicinal chemistry, or to use AI to read 600,000 pathology reports that we get for the SEER database every year, or to use artificial intelligence for image analysis, both pathology images and radiology images. So I think this is a tremendously exciting technology that has real opportunities to advance cancer research and cancer care in many important ways. I think we are also worried about the ethical issues of AI, and we want to make sure that we use practices that will not reinforce biases that are latent in some of our data sets. But overall, I think the promise of AI is very exciting for cancer research.
Interesting. Okay. Dr. Gibbons, the budget request includes $110 million to study the impact climate change is having on health. Talk to us about what kind of serious effects have we been seeing from climate change, and what kinds of research do you expect NHLBI to support with this kind of funding?
Yes, thank you for that question. As we know, climate change often involves these changes in our air and our air quality. Particularly, it's likely to promote more air pollution. Certainly the constituents on the West Coast are familiar with the impact of wildfires on air quality. And although air is all around us, air pollution tends to concentrate and have its greatest impact on certain communities, particularly communities in which those neighborhoods are closer to sources of air pollution, and therefore the impact is also inequitable in terms of the health consequences of air pollution. And that's falling on the most vulnerable. We know that it exacerbates certain chronic conditions, certainly cardiopulmonary ones like chronic obstructive pulmonary disease, asthma, heart failure. Heart attacks are increased in the context of higher air pollution promoted by climate change. And we anticipate that there'll be a need to not only mitigate the impact of climate change, but also to enhance resilience to the effects of air pollution on health. And we anticipate that will involve enhancing healthy communities that are disproportionately affected by the consequences of air pollution derived from climate change. And our programs that are in community engaged research with that health equity lens should be promising in that regard.
Okay, I think this is really important, and I think we all should recognize that this is an area we need to look at. So I appreciate your work on this, and we'll be following it closely. I will turn to Senator. Okay, I have one additional question, and that's for Dr. Collins. In 2018, the National Academies, as you know, released a report that found that nearly 60% of women in academia have experienced, 60%, have experienced sexual harassment on the job, and recommended that federal research agencies require institutions to notify them when individuals on grants have violated harassment policies or put on administrative leave due to harassment allegations. And other science agencies like National Science Foundation have implemented these changes. Tell me, what is NIH doing to require its research institutes to do the same?
Senator, I share the sense that this is an extremely important issue. The National Academy report that you mentioned, I think, really got everybody to recognize how pervasive sexual harassment is and what a significant negative it has been for far too long for women in our scientific workforce. We conducted our own working group in the advisory committee to the director that reported to me in December of 2019 and made a series of very significant recommendations about how we might change our approach to this. We have been working through those and have already implemented a significant fraction of them. There are some that still require some additional legal authority that is hard for us to be able to do at the present time. In terms of what you're particularly pointing to, we have had now more than 300 allegations that have been brought to us about sexual harassment in our grantee institutions, others within our own intramural program. Of those 300, about 30% of them have been turned out to be actually entirely validated. That has resulted in 100 different changes in grants, that particularly removal of principal investigators and replacement of those with other individuals. 125 individuals have been taken out of our pool of peer reviewers because of this kind of concern about the bias that they bring to that experience. And we have made it very clear to our institutions that we expect them to report in any circumstance.
Well, expecting them doesn't require them to.
And Senator, you and I are in an interesting discussion here that I agree. I wish we were able to simply say require. At the present time, legally, we are told we don't have that authority. We would have to go through a 2-year rulemaking effort, or we would need statutory assistance.
Well, okay, this is really important, and whatever we need to do, I know you've worked on it, I know you've focused on it, but I know of women who have left our scientific research institutes because of this. We can't afford to have that happen for 1,000 reasons. So whatever it is we need to do here, we need to know what it is so we can do it.
I'm so with you, and if there's another iteration we can take at this to try to figure out. I will say that what we've said in terms of expecting response from our institutions has gotten their attention in a pretty remarkable way. Even without requiring it, we are seeing reporting coming through.
Well, to every one of them is listening, I'm not done with this.
Okay.
Right. Senator Blunt.
Thank you, Chair. I've got 3 or 4 questions. Let me eliminate a couple of other topics by just making a couple of comments on some things that have already been said. One thing that hasn't, I don't believe, brought up today. One is on the CTSA awards. None of the people talking to us that are current recipients think that this simplifying the process makes it more likely that they'll get the research bench to bedside result that they think you want and they think is the key to this award. And, you know, you've heard a number of schools mentioned, and University of Washington would be one of them that Senator Murray would be very familiar with. Washington University in St. Louis collaborates through this program with St. Louis University and the University of Missouri to get to more rural hospital settings and do things. So I suspect you've heard a number of concerns about that today. I haven't heard brought up one of my concerns, which I'm just going to mention. I don't think you need to respond to it. I do think that waiving the intellectual property rights on these vaccines is a problem. I think it's a problem because I don't think it actually would increase the number of vaccines, the capacity to produce a vaccine that has efficacy in the time frame we need to make it. Probably isn't benefited much by waiving the rights to the research. The WTO has to unanimously agree, which I don't think they do, but if they do, we give our research to everybody. And third, when this comes up again, companies would have less willingness, I think, to step forward. At least one of the companies, Dr. Collins, that we dealt with in Warp Speed, there was no agreement at all that if they weren't successful, we had a contract, we'd buy 100,000 doses, but only if they were FDA approved. So they were out there totally on their own, as these companies you would expect to be. I don't think this is likely to happen because of the WTO, but I have some concerns that I suspect are shared by others NIH. Dr. Bianchi, the title, let's just take the title of your agency and look at COVID. What do you think the impact on child health and development of COVID and the COVID environment, the pandemic environment, the quarantine environment has been, and how are we going to be looking at what the long-term ramifications of that might be, and what advice we may be able to give to schools and moms and dads and behavioral health and other health providers as it relates to child development impacted by this?
Thank you so much for that question, Senator Blunt, because children, have not, I think they're so important in terms of our nation's future, first of all. But the fact that children have been home from school have affected the entire family, have affected the workforce, etc. But because children in general have been asymptomatic or mildly symptomatic, they haven't gotten as much attention. And yet being at home, being away from in-person schooling, I think may have significant impact for years to come. And for that reason, we're trying to get kids back to school as soon as possible. And as part of the RADx Underserved Population program, we are also leading an initiative to really develop, evaluate, and implement testing along with mitigation of hand washing, social distancing, et cetera, to get evidence to reassure people to get kids back to school. 2 of the sites are actually in Missouri, and 1 is in Washington State. There's a program in Yakima, and there's a special program in Missouri that is looking at how do you deal with kids who have intellectual disabilities and can't mitigate in the same way. So to answer your question, I think there will be long-term effects. I think the answer is to get kids back to school safely with evidence. And this program is based on a funded project that was very successful in North Carolina that showed with all the mitigation, with the work with the superintendents of schools, that the secondary infection rate in schools was extremely low compared to the community.
Yeah. I would think here that some of the developmental issues, and they'll be different with 4- and 5-year-olds in kindergarten and first grade than they will people in 7th grade, and those may be different than people Absolutely. In the 11th and 12th grade, and how, I think we're going to have to watch this carefully and try to get data and then share that data on vaccines, actually on maybe more on mRNA than vaccines. What do we think as it relates to cancer, to HIV? We'll start, Dr. Fauci, with you. Can we look at the flu shot in a different way? And what do we think the mRNA impact, now that we know this different use for it, may have on other healthcare settings? And Dr. Sharpless, I'm going to come to you second on this.
Yeah, I believe, and many of my colleagues believe, that the mRNA technology, as it has been so spectacularly successful with SARS-CoV-2 to develop a vaccine against COVID-19, is already being pursued for other infections, including HIV and including influenza. So there are a couple of things that are going on now, even as we see the successes with COVID-19, is using the mRNA technology for the development, for example, of universal flu vaccines, as well as now having HIV vaccine researchers now looking at the possibility of an mRNA platform technology to use for HIV. So it's already happening.
Dr. Sharpless, on mRNA, I mean, we know the impact in just the last half dozen years of immunotherapy on cancer treatment. What about this mRNA intervention and how it might impact the way we look at fighting cancer?
Yeah, this is a very exciting topic. People interested in this space have been working on this, long before the pandemic. So using mRNA for cancer therapy has many potential applications, because you can really get the body to make a protein, and that protein could have a desirable effect against cancer, for cancer therapy in a lot of ways. The furthest advanced, as you mentioned, is the use of mRNA vaccines, cancer vaccines, and generally they tend to be highly personalized. The idea is that you can sequence someone's own tumor and then make the vaccine to their very own tumor in a way that won't cause them autoimmune side effects. And this is an idea to augment other kinds of autoimmune cancer or anti-immune cancer therapies. So it's a very promising area. It's in clinical trials, and we just need to see how this develops.
Thank you. My last question, Chair. Dr. Collins, in the pandemic, particularly with lab closings, we obviously lost some time, maybe lost research that it's going to take a long time to recreate. Are the lab reopenings happening in the way they need to? And do you have the flexibility to extend a grant to overcome the disruption, and probably not just this disruption of the time closed, but the research lost by closing as well?
I'm glad you're asking, because this is yet another of the terrible casualties of this terrible pandemic. It has been very hard on researchers, especially those who need a laboratory to do their work or who are running a clinical trial that was very hard to enroll participants. And yes, we did have to have many of those folks staying away from the workplace for their own safety. They're coming back. Our own program at NIH, our intramural program now is up to about 50% occupancy, but it's not anywhere near where it was pre-pandemic. We have done everything we can with our flexibilities to try to make sure, particularly the trainees and early stage investigators don't get further injured by this, by extending the periods of their training or by allowing grants if they are able to put forward a special request to be extended for an extra year, either without extra funds or with, if the case is strong. And yes, I also think we need to be cognizant of the way in which this is affecting people in other ways. We have now come up with a way to provide child care support for our trainees who otherwise have not had that, and that's been one additional burden on their shoulders. Our estimates are that it's about a $16 billion loss that has occurred because of the way in which this has affected research in our extramural institutions, that they are in a tough place to try to make up. So I appreciate your asking the question. We're going to have a really big challenge getting ourselves back into the place that we were before this happened.
Well, let us know what we need to be thinking about as we think about the rest of this bill on that topic. And thank you, Chair.
Thank you very much. And I want to thank all of our witnesses today for a really productive hearing. I think we all learned a lot. So thank you very much. For any senators who wish to ask additional questions for the record will be due 1 week after the President's budget is delivered at 5 p.m. The hearing record will also remain open until then for members who wish to submit additional materials for the record. The meeting is adjourned. Thank you.